the Mirena device, probably even using an implanon or Nexplanon, or using oral progestogens, that you minimize the rate of recurrence of this disease after good quality surgery. We can also use the levonorgestrel system in adolescents. And again, there are more and more anecdotal papers coming out around the world about the use of the levonorgestrel system in young women. This is a study from New Zealand where they have extensive anecdotal experience in adolescents. They found mostly straightforward insertions. It's often surprisingly straightforward to insert a Mirena into an adolescent, provided she's sexually active. In those young women who are not yet sexually active, then we would usually do a brief general anesthetic in order to be able to insert the system. But this can produce dramatic improvement in their endometriosis pain, as well as treating heavy menstrual bleeding in those that have it, or, of course, being a good contraceptive. Now, the new development in oral treatment, oral progestogen treatment, in the last 2 or 3 years has been the introduction of Visan, that is the progestogen Dienogest, and this is really just to show you visual analog score and a very slow reduction in pain over a 12-week period in those women who were treated with placebo, and the lower bar is the rate at which pelvic pain improved, pelvic pain with endometriosis improved in the women treated with Visan. And if you then go follow those up for, I think it was 3 years, more than 3 years, you can see that there is a continuing decline in the visual analog score recording of pain in those women who continued on Visan for that whole length of time. So this looks like a good progestogen. Whether it is better than what we've had for the last 50 years, we do not know, because all the studies with Visan have been against placebo and not against other comparators. Now, we believe that some of the reasons for these unusual pains and some of the difficulties of managing those pains in women with endometriosis come from the presence of nerve fibers, approximately 1/3 of which are sensory nerve fibers that appear in the endometrium of women with endometriosis, but are not present in women without endometriosis. On the left-hand side here, you can see a rather faint blue background with, this is obviously proliferative endometrium, and you cannot see any red structures within that. If we go to bottom right, you can see a thick red trunk at the bottom. This is a thick nerve trunk running along the endometrial-myometrial junction in a woman with endometriosis. We have never seen this in women without endometriosis, and we've looked at quite a number of hysterectomy conditions. Top right-hand side, you see those small nerve trunks moving up into the functional layer of the endometrium, something that we just don't see except on very few occasions in women without the disease. So there are unusual things happening with the nervous system in the pelvis in women with endometriosis. So this is just a list to remind you of the progestogens, the vaginal danazol, perhaps rarely aromatase inhibitors. They do have some troublesome symptoms, and most of those centers around the world that have done studies with aromatase inhibitors are no longer using them. It sounded like a good idea, but probably is not going to be beneficial. And then more and more use of combinations of hormonal therapy to prevent recurrences and to suppress the disease. Now, how do you manage patients who are resistant to all these conventional therapies and the surgery? Troublesome recurrences after surgery. Perhaps none of the conventional combined pills have suited a woman. Oral danazol or GnRH analogues have given her side effects. Non-medical therapies maybe have helped a little, but have not been sufficient to give her good quality of life. And so you need to move, of course, to effective analgesia, often using a pain clinic. And if you have a good pain clinic, then it's really valuable to use their expert input into managing these very difficult patients. And then moving to these combinations, these individual combinations, and individualizing the therapy. And we are now moving, in the great majority of these patients, to insertion of Mirena, insertion of Implanon or Explanon in the same patients at the same time, and finding absolutely dramatic results. We've had a total of 40 women who have completed at least a year or two of treatment. One of these is now on her fourth set of 2 delivery systems. 12 of those 40 women were teenagers with the most extraordinary disease, unable to go to school, totally disrupting the whole family, tried a whole variety of different therapies, and 4 out of those 12 got absolutely dramatic results in terms of no bleeding, no pain, and a very normal lifestyle resulting. The remaining 8 of those women did very well. They still had a little pain, but it was entirely manageable. And if we looked at the whole, at 30 out of the whole 40, we found marked improvement in 30 out of those 40. And do remember, these are women who we really could not control, or other gynecologists could not control, with standard approaches to therapy. We're not advocating this at all as a routine, but for those small numbers of patients who you found extremely difficult to manage, moving away from conventional therapies can be very valuable. We'll move away from that and look at final issues needing better understanding. We need to better understand the natural history of this disease and its variants. We need to undertake more effective assessment, classification of the range of different aspects of each individual woman's disease, predicting and managing treatment failures, planning or avoiding the need for repeat surgery, managing neuropathic pain, using long-term hormonal therapy, optimal management of infertility, use of newer medical and hormonal therapies, and of course all of this is bound together by more effective, good counselling and information. And you really do need to have that to bring things together, maximise the placebo effect, and keep an ongoing control of the symptoms arising from this disease. Now, we're procedural specialists. We get paid for operating, so we spend hours operating on endometriosis and minutes talking with patients. Should we not be spending hours talking with patients and their families and fewer hours operating? Good counselling and holistic management concepts ensure much more effective use and continuation of analgesia and hormonal therapies. And I do have one final slide which says, endometriosis is a systemic disease, and only when we recognise that and recognise the implications far beyond the reproductive tract and the recognisable lesions will we be able to manage this disease most effectively. Hormonal therapies and effective analgesia will play increasing roles over the next 1 to 2 decades. Approaches to prevention and prevention of recurrence of disease will become critical issues, and only a small minority of endoscopic surgeons will have the advanced skills and regular practice to undertake effective management of deep invasive disease. So, thank you very much indeed for listening.